Hello and welcome everybody. My name is Remco van Eenennaam. My apologies for doing this via video, but unfortunately I was unable to attend in person. I would like to thank the organizers for giving me this opportunity because it's very important to me to tell you about the stories and experiences of people with amyotrophic lateral sclerosis, their caregivers, and their healthcare professionals with decision-making on gastrostomy. The authors of the study have no potential conflicts of interest to declare. What is amyotrophic lateral sclerosis? ALS is a devastating and fatal neurodegenerative disease characterized by progressive loss of function that leads to increasing difficulty in swallowing and chewing and reduced upper limb function. In turn, this leads to weight loss and malnutrition, which are independent prognostic factors for survival in ALS. It also leads to dysphagia, aspiration, choking, and the risk of recurrent chest infections. Additionally, increasingly prolonged and effortful meals also cause people with ALS and their caregivers and family distress and negatively impact their quality of life. For all these reasons, gastrostomy is recommended in ALS for long-term nutritional support. However, people with ALS and their healthcare professionals experience decision-making on gastrostomy as complex. For people with ALS, it's often an emotional and difficult decision for many reasons. These include reluctance to give up eating, a desire to remain in control, and anxiety over the procedure, for example, fear of pain or hopelessness. As a result, they often postpone decision-making. This lack of patient readiness to engage in this decision-making is difficult for healthcare professionals. What is also difficult is the absence of clear evidence on optimal timing and efficacy of the procedure. In this study, we explored the experiences of people with ALS, their caregivers, and their healthcare professionals with the decision-making process about gastrostomy. How did we explore these experiences? We used semi-structured interviews in which you have a small set of questions you want to explore and you ask follow-up questions depending on the participant responses. We recruited people with ALS who had made a decision to accept or reject gastrostomy at multiple ALS care teams in the Netherlands. They were interviewed together with a caregiver because as ALS progresses, they often lose the ability to speak. People with ALS were also offered the opportunity to respond to the interview questions via email before the actual interview took place. These answers were then used during the interview to ask follow-up questions. This was only offered to the people who were unable to speak anymore. Then the interviews were transcribed and analyzed for themes. Additionally, we asked them which caregiver had supported them during decision-making and invited which healthcare professional had supported them during decision-making and invited this healthcare professional to also be interviewed. This was done separately from the people with ALS. In total, we interviewed 13 people with ALS and 12 caregivers on 14 cases. In one case, we only interviewed the caregiver because the patient was too weak and deteriorating too quickly to participate. 2 patients who participated did not have a gastrostomy. 1 person rejected it because the risk of complications was too high in his opinion. Another one rejected gastrostomy time and time again until he finally changed his mind, but by then he was too weak to undergo the procedure. Less than half of the people with ALS participating were able to speak and communicated in different ways, for example, through email, speech computer, etc. In 10 of the 14 cases, we were also able to interview the healthcare professional. Here you can see an overview of the themes we found when we analyzed the interview. Decision-making on gastrostomy was described as a continuous process, with people with ALS weighing up the future clinical need against their values, beliefs, and expectations, while being supported by significant others and healthcare professionals. Under intrinsic factors, we see physical necessity, feelings surrounding loss and identity, and expectations about gastrostomy placement. Participants explained that the weight of these factors shifted over time as the disease progressed. Extrinsic factors show that the decision-making process was a family affair, with caregivers supporting patient choice and healthcare professionals who also supported patients on their journey with ALS. Finally, and most importantly, feeling of control is crucial in this process. Participants described an absence of choice when confronted with the progression of their disease. But people with ALS said they retained control by controlling the timing of decision making and because of support from significant others and healthcare professionals. Let's discuss these themes in more detail. When weighing the benefits versus their concerns about gastrostomy, participants came to different conclusions. Some explained that their concerns weighed more heavily than the clinical need and possible benefits, and they declined or postponed decision-making as long as possible, as shown in quote 1, who said it was a pragmatic decision which he postponed. Emotions associated with loss and identity played an important role, and gastrostomy was often viewed as a threat to their identity and independence. However, over time, the weight of these factors would shift as the disease progressed, until they were forced to make the hard but necessary decision. For others, however, it was a much easier decision, and they accepted gastrostomy because physical concerns and quality of life trumped their emotions. However, participants revealed a paradox when making a decision in the absence of choice, as can be seen in quote 2, where someone calls eating a downright disaster and the decision a fait accompli. Almost all participants, regardless whether they initially accepted, postponed, or declined, felt at some point during the disease that gastrostomy was inevitable because of the physical deterioration. Nevertheless, despite this absence of choice, people with ALS felt in control and agency over the decision-making process because they were able to decide on the timing of, and their final decision, as we can see in quotes 3 and 4. Then we come to the second theme, the intrinsic factors. Physical necessity acted as a factor pushing people towards accepting gastrostomy. Participants described how over time, mealtimes became increasingly difficult, with eating and drinking becoming harder. Quote 5 sums it up by calling meals a true disaster and a confrontational drama. Meals become a struggle, and it also becomes a struggle to not lose weight, get enough energy, and stay healthy. And safety also becomes an important issue due to aspiration and choking. On the other hand, emotions about loss and identity would make it more difficult to accept gastrostomy. For some, it symbolized a loss of independence and taking away their autonomy as a human being, as we can see in quote 6. But also the loss of enjoying a meal, being together with loved ones, and the loss of body integrity, because there has to be put a tube into their body. Finally, some said they postponed decision-making because they were afraid of the intervention. They were afraid of pain or anxiousness over their helplessness and inability to communicate, as we can see in quote 7. The final theme are the extrinsic factors outside the person with ALS. People with ALS and their significant others describe the decision-making process as a family affair, as we can see in quote 8. Nevertheless, partners and caregivers emphasize the importance of respecting the choice and autonomy of the person with ALS and supporting them in making their own decision, like the partner in quote 9, emphasizing it is his body and his decision. They did this despite the difficult mealtimes adding to the burden of the family. People with ALS and their caregivers also said that healthcare professionals supported them during their journey, respected their autonomy, values, and dignity, and gave them the time to come to their own decision. Healthcare professionals did this by providing person-centered care, taking the time to listen and understand what was driving the person with ALS, as we can see in quote 10. Information was also crucial in helping people with ALS come to a decision. For example, possible benefits, experiences of others, being able to keep eating, and reassurance about the intervention were deemed helpful. However, some said they would have wanted more information about possible complications and drawbacks. In conclusion, people with ALS describe gastrostomy as inevitable due to the progressive nature of ALS and as having no choice but to accept it. However, they are able to feel in control when supported by their loved ones and healthcare professionals to make their own decision in their own time. Due to its progressive nature, the journey with ALS is one of loss of control over the body, and normal things like the ability to speak, to eat and drink and participate in enjoyable activities go away. As a result, people with ALS try to retain and regain control over their healthcare, and patient choice is crucial to this feeling of control. In gastrostomy, this varies from early acceptance, postponement to initial rejection. All of these are strategies to keep control over the decision-making process based on an individual weighing of values and needs. Regular discussion is necessary when gastrostomy may be indicated, especially with patients who postpone decision-making or reject gastrostomy, because the latter may turn out to be a no, not yet, rather than a no, never, as we see in quote 11. As we saw earlier, with one of the patients who rejected gastrostomy so long that he ended up being too weak to undergo the procedure when he finally changed his mind. What would I like you to take home from this? The decision-making process is not easy for healthcare professionals due to the absence of evidence, lack of patient readiness, and the risks underlying postponement. However, you can support people on their journey with ALS by providing person-centered healthcare. Discuss gastrostomy early and regularly, allows people with ALS to get used to the idea, and inquire about their values and preferences on this topic. Emphasize that you will support them in making their own decision in their own time, like the healthcare professional in quote 12. Include also caregivers in this process, because they are crucial in supporting the decision-making process and autonomy of the person with ALS. Healthcare professionals walk a difficult tightrope between explaining clinical benefits versus drawbacks, exploring and accommodating values and preferences of people with ALS, and respecting patient choice. However, if they do this, in the end, this helps to support the autonomy of people with ALS, helps them feel in control, and increases their satisfaction with the decision-making process. All of which we can see in quote 13. Finally, I would like to acknowledge and extend many, many thanks and gratitude towards all the people of ALS and their caregivers who shared their valuable time and incredible, heartfelt stories with me for this study. It was truly inspiring and humbling to hear your stories. Of course, also thanks to the healthcare professionals who made time to be interviewed for this study. I would also like to thank Nele Rave, the student assistant on this project, who did an amazing job together with me, interviewing participants and analyzing the results. And finally, a big thank you to the rest of the research team. If you have any questions about this presentation, the principal investigator, Dr. Anita Bele, will be in the lobby besides our poster, and you can also email her on this topic. Thank you very much for your attention.